I'd like to say we are very appreciative and very thankful that Dr. Piacentini is presenting this morning. He is a board certified clinical child and adolescent psychologist and professor in the UCLA Department of Psychiatry and Biobehavioral Sciences. He directs the UCLA Child OCD, Anxiety and Tic Disorders Clinic and Tourette Association Center of Excellence. He also directs the UCLA Center for Child Anxiety Resilience, Education and Support. And I hand it to you, Dr. Piacentini.
Thank you, Julian. It's a pleasure to be here to give this talk. I did a similar talk a few years ago and enjoyed that experience, and I'm sure I'll enjoy this experience as well. I have a lot of information in this talk. I'm going to go through it. I'm probably not going to hit every point on every slide. It's just too much, but you will be getting a copy of this. So I'm going to probably focus more on the high points for this, given the time that we have. Very briefly, I do have some disclosures, nothing relevant to this presentation, but in the US, we present these, and I'm assuming it's probably similar in Canada. And what I want to talk about today is really the defining features and clinical correlates of BFRBs, body-focused repetitive behaviors, and BFRBDs, body-focused repetitive behavior disorders. And then provide an overview of current best practice treatment approaches. I think one of the highlights of this talk is that we have recently finished a relatively large precision medicine initiative on body-focused repetitive behaviors, sponsored by the TLC Foundation, which is the largest in Canada, maybe the world, I don't know, support organization for individuals with skin picking, hair pulling, and associated disorders. So I have some data there that I think is going to be interesting. And also I think it'll be interesting in terms of how it informs our approach to treatment. So let's just start at the basics. I'll move through this stuff pretty quickly. What are body-focused repetitive behaviors? Repetitive self-grooming behaviors directed toward a part of one's own bodies. To meet the requirement for being defined as such, they cause physical damage, impair social occupational functioning, or would cause damage if ongoing. And this would be the requirement for a diagnosis. And in the DSM, current DSM, BFRBs, actually trichotillomania and skin picking or excoriation disorder are classified as OCD and related disorders. So they're in the category with OCD. But there are certainly BFRBs that do not have current diagnostic classifications, such as nail biting, cheek biting, lip biting. I'm going to talk mostly today about hair pulling, which is trichotillomania again, and skin picking or scratching, which we consider skin picking disorder or excoriation disorder. So what are the DSM-5 criteria for trichotillomania? Recurrent pulling out one's hair resulting in noticeable hair loss. Attempts to stop but unable to stop. And the hair pulling can't be better explained by the symptoms of another mental disorder, for example, body dysmorphic disorder. The hair pulling or hair loss can't be attributed to another medical condition, such as a dermatologic condition. And the disturbance causes clinically significant distress or impairment. So when we're looking at somebody that comes in with hair loss and we're thinking of potentially about trichotillomania, a couple of rule outs to think about. It's not diagnosed when hair is removed for cosmetic or grooming concerns, or for those who only twist or bite their hair. As I'm going to describe later, people do a lot of things with their hair. They can twist it, they can bite it, they can play with it, they can chew it off, they can swallow it. If you only twist or bite the hair but don't pull it out, it's not considered a diagnosis of trichotillomania, although it still could be considered as a body-focused repetitive behavior. And as I said earlier, I believe it's not performed solely to improve a perceived defect or in response to a fear or an obsessive thought. And when we see cases coming in, oftentimes we'll need to rule out alopecia as the cause. Skin picking disorder, pretty similar, different target, but the requirements for a diagnosis are pretty similar. Recurrent skin picking, scratching, digging, or rubbing resulting in scarring or broken skin. Repeated attempts to decrease or stop without success leads to clinically significant distress or impairment. And the behavior can't be attributed to the physiologic effects of a substance, for example, cocaine or amphetamine use, or another medical condition. nor can the skin picking be better explained by the symptoms of another mental disorder. For example, delusions, tactile hallucinations, again, body dysmorphic disorder, stereotypies, or self-harm. And when we're thinking about a differential diagnosis for skin picking, body dysmorphic is probably one of the most common, although it's important to note that you can be diagnosed with skin picking disorder and body dysmorphic disorder at the same time. We saw a little girl about 12 in our clinic several years ago who picked her face because she perceived pimples that she didn't like. And she wore like a lot of makeup to cover them. That would be body dysmorphic disorder, but she also picked her arms because of this persistent urge to do so. And again, if it's response to an obsession, picking due to acne is not likely to rule out skin picking disorder. If the picking of acne on the face or other is meets all the other requirements for skin picking disorder, then we would consider that. A lot of kids and adults or adolescents do pick their skin, pick acne to try to pop the zits. There's the YouTube channel, I believe it's on YouTube, the zit squeezers, pimple poppers. If it is excessive, if it causes skin damage, if it's impairing, if the individual wants to stop but can't, it's a skin picking disorder. If they enjoy it and are not interested in stopping, it's not skin picking disorder. So BFRBs live in the OCD world. And how do you determine whether it's a BFRB or it's a symptom of OCD? So again, I've addressed some of these already. You can look at this list. BFRBs, they're not doing it because of harm avoidance. They're doing it for gratification, not escape from distress. Typically an earlier age of onset with BFRBs. BFRBs really don't respond well to medication. OCD responds pretty well to medication. Treatments are a little bit different. And the primary issue is BFRBs are egosyntonic. That is, patients that pull or pick, they're doing it because they want to do it. And they find some pleasure in it, even though there may be negative consequences. OCD is ego dystonic by definition. I don't want to do these rituals. They make me feel good, but I'd rather not do them. I'm going to talk a little bit about some of the clinical characteristics for adults and children. And these data come from the Trichotillomania impact projects that were funded again by the TLC Foundation in the early 2000s. And these were internet surveys. So they do have some limitations in that regard, but the adult survey, 1,697 participants that met eligibility for engaging in the survey, and even for the child, 133 youth, most of whom, some of these youth presented information, parents presented for others. The one thing you can look at is in the adult study, 93% were female in the adult informants, and for the kids, 86% of the youth that were reported on or reported on themselves were female. So there may be a bit of a skew towards females in this sample. But what we learned from this study were the most common pulling sites. Again, if you've worked with this population, this shouldn't be a surprise, except that they were pretty similar across adults and youth. Scalp, by far the most common. Eyebrows, quite common as well. And these are both easily accessible. I mean, it's easy to find your hair and your scalp and your eyebrows. Eyelashes, more so in adults than youth. Pubic, more so than adults and youth, because some of the kids were prepubertal. Legs and arms were pretty similar. And in the youth study, 58% reported multiple places. I don't believe we asked that question in the adult study. Pulling characteristics, almost all pullers described anxiety after pulling, unpleasant urges prior to pulling preceded by some kind of a body sensation. The urge would increase when they resisted pulling. They were aware of their pulling, and lesser number pulled to achieve a certain bodily sensation. The actual act of pulling was what they were going for, and very few said they were pulling was preceded by symptoms of anxiety. Now, these may not be completely accurate, as we'll talk about later, but from this sample, this is what we got, and I think it's reasonably representative. Also in the TIP survey, again, it's about 15 years old, so things may have changed a bit due to greater awareness. but a small proportion reported tobacco use reduced their urges to pull. About a similar number, they drink to relieve negative feelings associated with pulling, or reduce urges to pull, or other substances to reduce urges. And 70% of the sample believed that pulling led to the development of an additional emotional disorder. And we know there's a lot of comorbidities associated with this, but it's interesting that they believe that the pulling was the precursor to these other emotional disorders. And I'm going to show you a little data in adults that may support that, may not. So in youth, the youth survey, again, a much smaller sample, the pulling severity was similar to what we saw in adults. About a third reported never or almost never experienced tension prior to pulling. About an eighth of them never or almost never experienced pleasure, gratification, or relief after pulling. And only 4% said they were never or almost never aware of pulling, much less than adults. So from this regard, it may be that children tend to pull more intentionally, that it's more of a habit for kids. They may enjoy it, they may not enjoy it, but it's not really driven by other factors, internal or external. And over time, as pullers and pickers mature, they may start having more of an emotional overlay on these symptoms, because we know that depression, anxiety are quite common in older pickers. It may be secondary to the pulling or picking, or it may be just representing the natural developmental progression of these disorders. We know that depression and anxiety, depression really onsets in adolescent and young adulthood for the most part. And we know that anxiety tends to get worse as well, especially social anxiety and maybe generalized anxiety. So it may be that these child pullers, the depression and anxiety that they report as adults being the result of their pulling may actually just be the development of these disorders independently of the pulling. And a study that we did, Adam Lewin, who was my postdoc at the time, based on this sample, we demonstrated that the comorbidity increases very dramatically with age. So you can see the kids in the sample at age 10 to 13 reported pretty low rates of mood and anxiety. And if we looked at those youth that were 14 to 17, you can see that these rates more than doubled, almost tripled in some cases. So you can certainly see that depression and anxiety increase with age. Again, whether it's the sequelae of the pulling or just the normal development, we don't really know at this point. The physical consequences of BFRBs, again, can be quite dramatic: baldness, alopecia, scars, wounds, infections, repetitive strain from hands and fingers from pulling, calluses, dental impact, and trichobezoars, which affect up to about 20% of hair pullers. And trichobezoars, especially in children, can be quite dangerous. We had a girl in our clinic, a 5-year-old girl, who swallowed her hair, and she had undergone one surgery, abdominal surgery, to pull the hairball out, which was quite large and causing some pretty significant problems. And the surgeons referred her to our clinic, saying that if she continued to do this, it could be lead to extremely serious complications. So the demographics, these are pretty broad intervals. We know that for trichotillomania, anywhere from 1 to 5%. Most of the earlier studies were self-report surveys on college campuses or of adults. We never have had a really good population-based survey until 2020. And John Grant and colleagues did a survey of 10,000 adults that were randomly selected. I believe it was through random calling. And what they found was that the rate was 1.7% in these adults. Excoriation, which was a bit higher, that's pretty similar to what we'd seen before. Excoriation disorder, all of the data suggested it's more common than trichotillomania, perhaps by a magnitude, maybe up to 4%. But again, there haven't been any definitive prevalent studies for this. And with regard to the gender ratio, in children, it tends to be 50-50 children, boys and girls. In adults, the surveys really talked about 80 to 90% female. It was almost thought to be completely female. But in the John Grant study of the community-based sample, he found, or they found, equal rates for males and females, 1.8% of males and 1.7% of females, which really was a bit of a shock to those of us that study trichotillomania. And it may be that trichotillomania in males has been as common, but they're just much less likely to seek treatment. The other thing about males is picking from facial hair is pretty easy to camouflage, and many men are bald, so picking from the scalp, either tonsorial or from the front hairline, losing hair there could look just like balding. So men may have been much less likely to come in out of shame or whatever it might be. Skin picking, the limited data we have suggests 80% female, but again, it could be higher in men. We just don't know. And then onset age, about age 12 on average for trick, about 15 for skin picking, although the ranges are quite large. And in very young children, toddlers, there's something called baby trick. And if you've ever seen a baby sucking on the blanket, at age, 6 months or 1 or 2, hair pulling can be pretty common with these kids. And in many cases, they can pull all their hair out. We've seen some young babies who just, in the same way, it's equivalent to thumb sucking, and it may happen while thumb sucking. This is often time limited or self-limiting. As the children get older and grow, in the same way that they stop sucking their thumb, they may stop pulling, but it can be persistent over time. So what are some of the myths about BFRBs, myths and misconceptions? So here's some things that are patently false, based on research, but probably mostly on clinical experience. People who engage in BFRBs are very anxious. Well, we know that anxiety is increased in those with BFRBs, but the anxiety isn't necessarily driving the BFRBs themselves. Hair pulling and skin picking are a sign of serious psychopathology, psychosis, whatever else that might be. Again, we know that's not true. We do see serious psychopathology in this population, but it isn't necessarily caused by the BFRB. BFRBs are self-mutilation. People do this out of hate for themselves, or they want to mutilate or torture themselves for whatever reason that might be. We know that's not the case. Although people that pull can lead to some self-mutilization, that's not mutilation. That's not the cause of this. That's not what's driving these behaviors. And people with BFRBs were likely abused as children. Clearly, that's false. BFRBs are simply habits that can easily be stopped. That is very false. There's no good treatment for BFRBs, as we're going to see. That's also quite false. And BFRBs are just another form of OCD. So the BFRBs are considered now as a member of the class of disorders called OC-related disorders, based on a variety of data, including some genetic data. But they're not just another form of OCD. They differ, as we saw earlier, in a number of important ways. And there are a number of people, I think myself included, that really don't see BFRBs as a subset of OCD. If anything, in my mind, BFRBs seem more closely related to Tourette's or to tics, because oftentimes they are triggered by some feeling to engage in a behavior, and pulling relieves the behavior, but it also can be described as something that's pleasurable, or it's something that feels good above and beyond just making the urge go away. And we know that in OCD compulsions are driven by, people don't necessarily like the compulsions, they do it to make the bad feelings go away. And BFRBs seem to be a little different than that. You may have heard people talk about intentional pullers. These are people that know they're pulling, they focus on their pulling. And oftentimes for these folks, some of the behaviors associated with intentional pulling would be searching. That's part of the process. They're rubbing fingers over their skin. They're looking for irregularities in their hair. I have to find the kinky hair, the white hair, the fat hair, the thin hair, or some kind of a bump or irregularity in my skin to focus on. And these would be intentional pullers, that they're pulling in certain ways and certain areas in certain areas. And sometimes with intentional pulling, individuals may rub the hair, smell the hair, chew the hair, and even swallow the hair. So this is and where trichobezoars would come in. We also know about pulling by proxy. So some kids and maybe some adults pull hair from family members, pets, dolls. They pull carpet hairs or carpet filaments, and that's called pulling by proxy. And we've had a number of cases where the mom will come in and say, yeah, I mean, my daughter wants to pull my hair. And certainly we've seen a number of cases where they pull the pet's hair. And that would also be diagnosed as a BFRBD. So when we think about treatment, we think about this tension relief cycle. This has been kind of the traditional way to think about BFRBs, and you should recognize this from OCD. In OCD, I have a bad feeling, an urge that something bad is going to happen. My anxiety builds. I can't manage it. I engage in my compulsion. I say my prayer. I wash my hands. I clap 2 times, whatever it is, and the bad feeling goes away. Similar to Tourette's. In Tourette's, I have this premonitory urge that is really uncomfortable. And even if I don't want to do my tic, I do my tic to make that urge go away. I can't stand the urge, and the urge disappears, and I feel better. We can even think about this negative reinforcement cycle with regard to anxiety. There's a scary dog there, and I'm really afraid of dogs, and I'm starting to panic. If I leave the situation, then my anxiety decreases and I feel better. These are all negative reinforcement cycles. And this has historically been a way of thinking about and structuring treatment for BFRBs, and it certainly occurs in a number of cases, but not all cases. And we're gonna talk about that right now. And I want to switch gears a little bit and talk about a large study. I think I referred to this earlier, the BFRB Precision Medicine Initiative, or the BPMI. This was funded by the TLC Foundation. There were 3 initial recruitment sites. John Grant, who some of you may know, is an expert in BFRBs, probably more than anybody, at the University of Chicago. Our group at UCLA, and Nancy Cuthin, who's very well known for her work looking at dialectical behavior therapy and trichotillomania at MGH. We added a 4th site in South Africa, Stellenbosch, led by Dan Stein. And some of the data will be from the South African site also. So the goal of this was to identify distinct BFRB profiles based on behavioral, genetic, and biological indicators that we could use to understand, recognize and understand underlying biological mechanisms, and then develop interventions specifically designed for these mechanisms. So there have been a number of treatments that have used this mechanism now. And the way we did this is we had a number, 364 individuals with skin picking, trichotillomania, and healthy controls that all underwent a variety of genetic, neurocognitive, brain imaging, and clinical data. So we developed, based on these data, we identified subtypes, phenomenologic or clinical subtypes of these individuals based on the sum total of the data that we collected. And then we tried to superimpose these clinical subtypes on the imaging data to see if we could identify specific brain functioning or brain activity associated with each one of these. And if so, then that would give us some understanding of the biological mechanisms that might lead to different BFRB presentations, and that might lead to biological, medical, or even behavioral interventions. We had some success with this. I just want to run through a couple of relevant findings here, and then move on to how these data, as well as other data, influence our approach to treatment. So here's the investigative team. You can see there are a number of people here. Some you might recognize from the literature. And what we did, based on our clinical data, we identified 3 subtypes of trichotillomania. Now, these make sense when you look at them. They don't necessarily overlay on our typical, on some of the prior ways that we thought about subtyping trichotillomania. We used to think about automatic and impulsive were the two subtypes that we had. There's a little bit of overlap here, but it's not exactly the same. But so let's talk about these. The first subtype were sensory sensitive pullers. This was focused pulling. These individuals had infrequent and low intensity urges in pulling, but when they did pull, it really was sensory. They felt like some need or some urge or some physical sensation that drove them to pull, and described some sensations associated with the pulling as well. By far the largest group was called low awareness. And this was automatic pulling. And this was emotionally triggered pulling. So these individuals said, yeah, we don't really have like huge urges. It really is automatic. When we're upset, when we're stressed, whatever it might be, we just kind of automatically start pulling. Um, and they said, and this group would tend to be more impulsive. And then the third group was called impulsive perfectionistic. This was the group that really had strong urges, and they were really unpleasant. They were unable to resist the urges. There were higher rates of mood and anxiety disorder, perfectionism, poor distress tolerance, and higher impulsivity. So this was probably the least well-performing group. They had everything stacked against them. Strong urges, they couldn't resist the urges, a lot of comorbid psychopathology, which really led them to pull. And there were two skin typing subtypes that we found. And the first was really the vast majority of skin pickers fell into this group, emotional and reward. Strong, frequent urges, automatic and negative emotion triggered picking, little control, perfectionism, and ADHD. These folks just picked their skin. They couldn't control it. Sometimes the urges were very strong, and they really had little control. And there was a functional group that really was most likely just a lower lower intensity version of the large group. This was a less sick group, mild symptoms, lower urges, little distress from picking, and some sensory issues. So they're not qualitatively different, probably quantitative in terms of the intensity of their emotions, intensity of urges, and intensity of pulling. So we also wanted to get a sense of what pulling and picking, what were the neural correlates of these three groups, to see again if we could identify these specific subtypes, which would then lead us to personalized interventions, if we could develop different interventions or implement interventions differently for these three groups. So we found that the low awareness pullers showed increased cortical volume in the lateral occipital lobe versus the other two groups. And this may be related. And again, this is highly speculative. And I'm not an imager, I'm not a neuroscientist, so I couldn't go into more detail than I'm going to because I don't have that depth of understanding. But this may be related to touch proprioception related sensory activation. In other words, recognizing the sensitivity of touch and pulling and the sensations of hair in this group, reflecting that. Maybe not causal, but reflecting actually sequelae of the pulling and the focus on sensation. The impulsive perfectionistic pullers, again, this was probably a pretty severe group, showed decreased volume in lingual gyrus compared to the controls. And what does this mean? Well, this area and pattern is related to response inhibition in the context of negative emotions. And this makes a lot of sense. One way to interpret this as we may be able to inhibit unwanted responses pretty well when all things are going well, but in the context of negative emotion, of upset, of arousal, emotional arousal, our ability to inhibit responses may be impaired in this group. So less control over their behaviors in this situation. And that certainly describes hair pulling in a number of people. So this doesn't necessarily support the full validity of these different subtypes, but it does provide us potentially some clinical clues in terms of how to differentially treat these people, which was somewhat of the goal of the study. We also looked at reward processing across these groups. And we found the BFRB group had marked hyperactivation of a certain area of the brain during controls, during a money incentive task. The BFRB group increased activation in multiple brain areas during anticipation of loss. So this was a risk reward, um, you know, paradigm here where you could win some money, or you could lose some money. And during loss, during anticipation of loss, greater activity in a number of brain areas. And collectively, the findings from these scans suggest a dysregulation in reward circuitry in BFRBs, which again isn't too surprising. And it may be that folks with BFRBs or within this subtype of BFRBs overreact to anticipation of reward or punishment. And it makes it difficult for them to make correct decisions. And this is pretty consistent with what we found before. Because if you think about pulling or picking, there's certainly a significant cost to these behaviors. Even though it may make my negative feelings go away, make the urge go away, I'm paying a price for this. And collectively, these imaging studies suggest that folks with BFRBs are unable to inhibit the pulling and the picking, leading to damage in anticipation of negativity. They're unable either to manage their negative emotions, their negative feelings, their negative projections, or in these situations, which again has some pretty important treatment implications. We also looked at inhibitory control in BFRBs, and this is not based on brain imaging, but based on some neurocognitive tasks. And we found some interesting findings here as well. Severity and impairment in trichotillomania was predicted by greater attentional impulsiveness or poor focus and greater motor impulsiveness. So this may be that folks with that are more impulsive or poor focus are more likely to pick or pull. And again, this may go along with those folks that pull out of attention, they do it automatically, or even those that do have impulsiveness in there. The more impulsive they are, the less able to monitor their behaviors or their behaviors, they may be more likely to pull. Very different pattern for skin picking, though. The skin picking severity and impairment was predicted by greater cognitive impulsiveness, which is future planning. So the less ability I have to think into the future and to maybe restrict unwanted behaviors that might interfere with the future, as well as avoidance of aversive experiences. So difficulty experiencing negatives. So I can't really think into the future, and I can't really manage aversive experiences. So when I'm feeling bad, somebody without skin picking or without these features, if I'm feeling bad, if I'm worried about the future, if I'm experiencing some negative feelings, sensations, thoughts, I might be able to manage to get through this, to disengage from these negative thoughts, to engage in other behaviors, knowing that these thoughts and feelings might go away. In skin pickers, when they have these feelings and thoughts, they can't really think about the impact of their behavior on future. They're more likely to pick. And overall disability was predicted by greater depression severity. So what does this mean in terms of treatment? So first of all, we think there may be different intervention targets for trick and skin picking. Very generally, with regard to the inhibitory control, for trick, addressing impulsive pulling by focusing on urge awareness and behavioral strategies to make pulling more difficult. So this is basically using habit reversal, using contingency management to really increase focus and awareness of the urge, and more active strategies for barrier methods for making pulling more difficult. And this would be stimulus control, things like Band-Aids on the fingers, wearing gloves, etc. For skin pickers, very generally speaking, exposure therapy may be helpful to increase the tolerance of aversive experiences in the same way that we treat OCD. Triggering these negative feelings and then working with the patients to resist the skin picking. And CBT related therapies to enhance focus on future planning may also be helpful. And again, this also describes the need to screen and treat for mood disorders, and we could put anxiety disorders in there as well, because we know that anxiety and mood and comorbidities are going to impair our patients' abilities to engage in any of these, increase the likelihood of pricking or pulling, and reducing the likelihood of treatment in the absence of addressing these other comorbidities. We know in terms of treatment, this is an older study done by Joe McGuire, another one of my postdocs, former postdocs, showing that the effect sizes for treatment for behavior therapy looks pretty high. This is really only for habit reversal training. We haven't looked at other treatments as well. Medication is not a lot of good data here. Medication may be helpful, but it would be very rare for medication only to lead to a remission of these behaviors. Nutraceuticals and acetylcysteine has been most commonly studied and used. Again, it seems to be helpful in a number of cases, but the data probably isn't there to fully support the use of this in all patients. The child and acetylcysteine studies were negative. So there's not a lot of evidence for younger children. Maybe older adolescents will occasionally use this in our NAC in our clinic. So let's talk through, we have a little bit of time left to talk through some of the different treatments. And in general, here's some general thoughts. A function-based approach is going to be quite important. It's really a must for working with BFRBs, given the heterogeneity of the symptoms, the heterogeneity of the correlates, and as I hope we've just demonstrated to some extent, the heterogeneity of the potential mechanisms or driving forces. So we need to look at the ABC model, antecedents, behaviors, and consequences. We need to understand what is the function that the pulling or the picking serves per the person. We need to understand what are you getting out of this behavior that clearly is damaging? Is it a reduction in negative feelings? Is it a reduction in an unbearable sensory experience? Is it a way to manage unwanted thoughts or other negativities? Because those are going to lead to different treatment approaches. We need to evaluate the individual's experience, internal and external cues and triggers, again, related to the above. And again, how these triggers are interpreted in processes. So somebody may say, I do this when I'm anxious, but not under all circumstances. So we need to understand kind of the behavior by environment interactions. So in which place, at which time, and which trigger. And again, this may lead to different interventions depending on the situation or the environment that the patient is in. We may be familiar with habit reversal training. We know awareness training, competing response training. I'm not going to go into these in any detail. There's a lot of information out there, but awareness training basically is increasing awareness of urges or triggers for picking and pulling, competing responses, and engaging in incompatible behavior. This is the primary treatment for Tourette's. A lot of social support, maybe relaxation training as well. And then the other component I alluded to earlier is stimulus control, identifying and managing pulling, picking triggers and activities. So somebody that pulls or picks when they're looking in the mirror would be to cover the mirrors. Somebody that picks or pulls when they get home from work, stressful, in the little bowl next to the door where you drop your house keys, you pick up some Band-Aids and put them on your fingers, you put gloves on, you put creams on, engaging in barrier methods that might make it more difficult to pull. Or you might engage in other activities that including relaxation training, etc., breathing to resist. The COMB, Comprehensive Behavioral Treatment, developed by Charlie Mansueto and his colleagues, is probably the most widely used intervention. Again, it just puts all of this together in a reasonably nice and a straightforward way to follow this. Again, it's from a functional analytic framework, building awareness of triggers and consequences, identifying interventions and implementing these interventions. The Hair Pulling Habit in You is a book for children by Ruth Golomb and Sherry Vavracek. It's basically COMB for kids. And there are a number of different manuals on this. You can see here the three that we tend to use. In the COMB model, they look for triggers and responses in three different domains: the sensory, the cognitive, the affective, the motor, and the place or environment. And this is the SCAMP model, SCAMP. And you can see identifying triggers and what's the intervention. Itchy arms would be sensory, maybe putting anti-itch cream on. Affective, feeling distressed, do deep, slow breathing when feeling stressed. In place, my hands are empty, I'm free to scratch. Might be playing games, doing a crossword puzzle, the squeeze ball, the ubiquitous squeeze ball, or koosh ball for pulling the hairs out of the ball rather than your head. And we know that exposure plus response prevention, there's a little bit of evidence suggesting that this might work for BFRBs. Hasn't been studied really well. The Brower and Grant reference here is a case study of 2 individuals. ACT-enhanced ART, this was really pioneered by Doug Woods and Mike Twuhig. They've done a study, they have a manual. Results are so-so, to be honest, but using acceptance and commitment therapy to emphasize commitments to value-driven actions, acceptance of urges, and focusing on what's important to you, that performing BFRBs interferes with. Again, the long-term data from this suggested it didn't come out as well as I think people would have liked. There are positive responses from this at the end of treatment, but by longer-term follow-up, the control group and the ACT group really didn't differ, which is what we find with a lot of these treatments. It's not just ACT. DBT-enhanced HRT, again, pioneered by Nancy Cuthan and colleagues, really using dialectical behavior therapy to address unwanted urges and negative emotions, and learning to manage and build tolerance of these urges and difficult experiences. Again, there's been 1 or 2 very small studies. More work needs to be done in this area. I want to finish up here and to leave time for some questions with some gold standards. So here, this is really based on what we've learned over our work with BFRBs, both prior to the BPMI study and after with the BFMI study results. Treatment should be tailored to the individual and their unique presentation. There's no cookbook approach. It's critical to prepare patients for treatment. This is often skipped. We need to assess motivation. We need to address readiness for treatment because this can be very difficult. If we just march through and the patient isn't ready, we're wasting our time and it's going to be a negative experience. We need to address comorbidities and we need to set realistic goals. We need to address patients' lived experiences, shame, abuse, negative self-evaluation. We cannot march in and assume all patients are alike. We need to work on self-acceptance, improve self-compassion, improving a sense of common humanity. We connect our patients through the TLC Foundation to others to let them know that they aren't alone. I have about 3 more slides and then we'll have, I think that should be enough time for questions, I hope, because I think these are the most important at the end here. Implications for treatment from the BPMI subtypes. Remember, we identified 3 subtypes. So how can we leverage these data? The sensory sensitive group, the focused pulling, infrequent low intensity urges. So obviously sensory interventions. Can we identify and incorporate soothing sensory experiences? If I'm very sensitive to certain feelings or whatever, I feel itching or tingling, I feel the need to move or do something with my hand, can we use other kinds of sensory tools to reduce these? For example, even a hairbrush. Can I move a hairbrush or put something, a fabric or something on my hand to reduce the need to pull? Environmental modifications, hiding any tools, keeping things around that are going to calm me down. Targeted interventions in specific environments. There are other ways to experience rewards and gratification other than pulling. The low awareness, automatic and intentionally triggered pulling, awareness enhancing techniques, executive functioning skills, stimulus control, again, Band-Aids for the fingers, gloves, hiding anything that we can use to pull with, competing response training, a la HRT, mindfulness and accepted-based interventions, and stress management skills. And the impulsive and perfectionistic, distress tolerance skills. I need to learn how to live with myself, to manage the fact that I'm not perfect, to try to tame my impulsivity in certain ways, emotion regulation, acceptance-based interventions, cognitive therapy to address these unhelpful beliefs and expectations, and delaying tactics. Can I do something to hide the scissors for a certain amount of, or tweezers for a certain amount of time so that I can't get at them? You'll notice there's a lot of overlap across these different subtypes and these different ways to do this. It's a matter of, again, understanding your patient and being able to develop a personalized intervention for your patient. And if steps 1, 2, and 3 don't work, you go to 4, 5, and 6. And if those don't work, you go back and you try some other techniques. But everybody's a little bit different here. Pharmacology, we don't have a lot of data. NAC maybe. SSRIs are often prescribed, but usually for comorbidities. There really is very little support here. And it's also important, if you work a lot with these disorders, to work with hair and skin professionals, because they know a lot about patients. If you're looking for referrals, maybe working with some of these folks can be very helpful as well. Acknowledgements here. I'm going to go quickly through this. And the TLC Foundation is certainly a resource here, www.bfrb.org. And I also found that you have your own Canadian BFRB support network. I imagine many of you may be part of that. But there are a lot of amazing resources to connect people with BFRBs. And the TLC has a conference every year. There's probably 100 sufferers, kids, adults, young adults, old adults, and it can be transformative for people to understand they're not alone and share things. And finally, I want to end with this slide that we can leave it on. This is the center that I direct. It's a center for supporting child anxiety. Tons of great resources for parents and kids related to anxiety, OCD, Tourette's, and BFRBs. There's a QR code there, and there's a lot of downloadable stuff and actually online courses that you can take. So please feel free to check that out. And I am going to stop there. I talked fast. I had a lot to get through. I hope you were able to follow, but I guess we'll find out during the questions.